Hello everyone, I'm Dr. Prabhachams and welcome to my learning space. So today we'll be talking about a 63-year-old gentleman who presented with exertional dyspnea and dizziness. On examination, there was abdominal distension, pedal edema, postural drop was positive. An echocardiogram was performed for evaluation of cardiac structure and function. So perhaps we already know what we're talking about. So this is a parasternal long axis view of this patient, and we can see that there is a sparkling appearance of the myocardium, and there is increased ventricular wall thickness. Overall, the left ventricular systolic function looks globally reduced. Additionally, there is a pericardial effusion. So yes, the ventricular wall thickness is increased, 12 and 13. And this is a short axis view of the left ventricle, and we can see, other than the pericardial effusion, that there is a mild global hypokinesia. Some more views, and this is apical four-chamber view. Here we can, other than appreciating the reduced systolic function, we can see that both atria are enlarged. The two-chamber view, confirming the same. Coming to the Doppler indices. So this is mitral inflow pulsed wave Doppler, and clearly we can see that there is dominant E wave measuring 1.3 meters per second. And then this is tissue Doppler velocity of the medial mitral annulus, and we can see that it is reduced, which reflects abnormal myocardial relaxation and compliance. This is pulmonary vein Doppler, and we can see that there is systolic blunting, and with diastole there is prominent diastolic flow. The LA volume index is enlarged, 41. This mild to moderate MR, mild TR with PA systolic pressure, with peak TR pressure is 20. And this is subcostal four-chamber view showing us biatrial enlargement and pericardial effusion. The IVC is not dilated, and it's collapsible, so perhaps reflecting that the patient is already receiving some treatment. Now coming to the strain analysis. So the average longitudinal strain of this patient is reduced, and it is minus 9.5. And if looking at the pattern of this strain, so there is an apical sparing pattern, what we call as characteristic cherry on top pattern, which by the way is pathognomic of cardiac amyloidosis. So if you take out the ratio of the apical strain to the basal to mid strain, and the value is more than 1.1, so this carries a high sensitivity and specificity for cardiac amyloidosis. So you have an increased ventricular wall thickness, biatrial enlargement, diastolic dysfunction, and pericardial effusion. So these findings suggest the possibility are highly suggestive of cardiac amyloidosis, and that's how you should put it down in your report, that the findings are strongly suggestive of a cardiac amyloidosis / infiltrative cardiomyopathy. And by the way, what is it? So either the transthyretin protein or the abnormal light chains. These misfolded proteins get accumulated into the myocardium and give these echocardiographic features. These are the red flags on cardiac imaging which should make you work more on it, such as the increased ventricular wall thickness, biatrial enlargement, and increased ventricular wall thickness relative to the low voltage ECG, diastolic dysfunction, severely reduced mitral annular Doppler velocities, reduced GLS, low flow, low gradient aortic stenosis, paradoxical one. With a normal ejection fraction, you still get a low flow, low gradient AS, pericardial effusion, increased atrial septal thickness, diffuse valve thickening, and preserved ejection fraction with low stroke volume index. So an increased ventricular wall thickness with a low voltage ECG is particularly suggestive of cardiac amyloidosis. Increased myocardial echogenicity, like the sparkling appearance, is not very highly specific. Atrial size and function is again non-specific. The interatrial septal thickness and thickness of the valves is again non-specific but suggests the diagnosis of cardiac amyloidosis. Doppler diastolic function assessment is helpful in determining the prognosis in these patients, and it's progressive as the disease progresses. The diastolic function is progressive. So a normal wall thickness, a normal LV mass, normal atrial size, and a very good septal or lateral mitral tissue velocity goes against the possibility of cardiac amyloidosis, whereas the other features that we've just discussed, if you find these, so these are strongly suggestive of it. Thank you, and please like and subscribe. Thank you.